Welcome everyone to our November community interest meeting for head and neck pathology. So I just want to start by, thanking our director, Dr. Anna Plotkin, and our amazing coordinator, Ms. Jenny Bozek, for making this event possible. And we, for everyone, just a reminder to complete a survey after our meeting to claim your CME points. Uh, before our this meeting, we conducted a brief survey, and we got 18 respondents. Half of them are from general pathologists, but also head and neck and oral pathologists. So we, just specifically asked for some questions related to our topic today, or epithelial dysplasia. So it seems that a majority of people use a three-tier system to grade oral dysplasias, and most of them uh, consider moderate dysplasia as a high-grade dysplasia in the two-tier system. Almost never will mild dysplasia excised at the people's institutions, and uh, frequently or occasionally will moderate dysplasia get excised. And most people said if the specimen contains active infection, particular fungal infection, they would prefer to ask for repeat biopsy and not go for dysplasia. Um, because most people are not sure whether lichen planus is a real or potential malignant disorder. But again, like we didn't have a lot of answers from head and neck and oral pathologists in this survey. So there's a even break when we ask people's attitude regarding ancillary markers in helping diagnosing these cases. And so I think today I'm really excited to have two of my colleagues to present their expertise in oral pathology and bring up some new studies or novel findings in this field. So first, Dr. Iona Leong is my colleague at Mount Sinai Hospital and also associate professor at Faculty of Dentistry U of T. And our second speaker is Dr. Yanchen Kevin Ko, who is practicing at BC Cancer, and who were trained in both head and neck and oral pathology. So without further ado, I'll let Dr. Leong start her talk.
All right, great. So welcome everyone. And I'm not really going to talk about anything very novel, but I'm going to talk about something that's pretty standard and that what most of us do every day. And I'm going to talk about the criteria that are used for the diagnosis of dysplasia. So firstly, the clinical context matters when we're trying to assess oral epithelial dysplasia. So dysplasia is a histologically defined term, and it occurs in the setting of oral potentially malignant disorders, which are clinical entities. And all of these are characterized by a variable risk of progression to squamous cell carcinoma, and hence a reason for grading dysplasia, because we believe that it gives us an idea of how likely the risk is of a lesion turning into cancer. So when I said clinical context matters, what matters is what what the lesion looks like, what other potential mimickers of this lesion would be like clinically. So what information the clinician gives you would be very helpful. And then it would also be related to where exactly the lesion is located. So there are certain sites in the oral cavity that are much higher risk for malignant transformation. And these are specifically areas like the ventral tongue, the lateral tongue, the posterolateral tongue, the floor of mouth, the retromolar regions. It also matters what it looks like. So if the clinician is able to give you information about the appearance of the lesion, that's very helpful. For example, in the top photograph, I'm showing you a lesion on the buccal mucosa, which is not really a high-risk site, but the appearance clinically is a little higher risk because it's a leukoplakia, a white patch that has heterogeneous appearance. And then in the bottom photo, I'm showing a lesion in a high-risk site, the ventral tongue, that also has features that are suspicious for high-grade dysplasia, such as areas of erythema and ulceration. And it's important to note that red lesions, mixed red and white lesions, erythroplakia, erythroleukoplakia, would be more likely to be associated with dysplasia or carcinoma. The other thing that the other reason that clinical context matters is that you need to know where the lesion is, because the oral mucosa varies a lot in appearance depending on the site. And we divide the mucosa into three types, whether it's masticatory, whether it's lining mucosa, or specialized mucosa. So the masticatory mucosa will always be keratinized, and this will be areas that come in contact with food, and this would be places like the hard palate, the gingiva, and in other sites where there is less exposure to food, then there would be less of a tendency for keratinization, and oftentimes fewer rete ridges. So, when you assess it, you would assess whether there should be keratin there or whether it should normally not be keratinized. And you would also assess whether there should be rete ridges or there shouldn't be rete ridges. There's also specialized mucosa, such as that on the tongue dorsum. So I'm showing you filiform papillae here that are characteristic of the tongue dorsum. And the reason this is important is because there are some verrucous lesions that I'll be showing you later today. There are also some other areas where the epithelium looks very cellular and might give rise to concern for dysplasia. And one of these sites is the posterior tongue. So on the posterior tongue, close to the foliate papilla, the mucosa often tends to look very crowded. The cells might look somewhat basiloid. And the trick to this is firstly knowing that it's from the posterolateral tongue. And the second is then to look for clues that it belongs to the posterolateral tongue. And here I'm showing you taste buds. So none of this that is shown in this slide is dysplastic. It's normal. Okay, so Lingxin mentioned briefly dysplasia grading. And the traditional grading uses 3 grades: mild, moderate, and severe. I put carcinoma in situ there because the current World Health Organization fascicle recommends not using the term carcinoma in situ and just using the umbrella term severe instead. But some of you may be used to using the term carcinoma in situ. So that's the traditional 3-tier system. And then there's a binary system which simply divides it into low grade and high grade. The advantage of dividing it into a binary way into low grade and high grade is that it just makes it easier for us and it makes us commit. Essentially, when we grade a lesion as low grade, it tells the clinician that maybe this lesion has a low potential for malignant transformation. Maybe it would be suitable to just monitor this lesion. And when we label it as high grade, we're telling the clinician the chance of malignant transformation is relatively high and maybe consider complete excision if it's clinically feasible. Using the 3-tier system does make it easier for some of us because it gives us a bit of wiggle room. Whenever you're not sure whether something is whether something's high-grade dysplasia or not, you might want to wiggle and you might want to, pop yourself somewhere nicely in the middle and call it moderate dysplasia. I personally don't have any preference for either the two, and of the 2 types of systems. And honestly, as the choice of system actually varies depending on the clinical situation. The problem with the dysplasia grading is reproducibility, and using a binary system, while it makes it easier to reproduce, sometimes it still leaves a lack of information, because I do think that there's information to be had from grading something moderate dysplasia versus something that's severe dysplasia. And also, predictive value is a bit of a problem because sometimes lesions that have low-grade dysplasia invariably go on to become carcinoma in any case. So there are always problems fought with the oral epithelial dysplasia grading. So if you look at the current World Health Organization fascicle and the criteria for dysplasia grading, you'll see that they've listed 28 features. 28 features is a lot of features. It's a lot more than was present in the previous fascicle. You'll also notice, if you actually went through the criteria, you'll notice that some criteria that were present in the previous fascicle, such as epithelial hyperplasia, aren't present in this one. And in the current one, many more features have been added. There are some problems with some of these features because they haven't really been very clearly defined. We were taught during residency to recognize these features, but if we were asked to quantify them, some of them are actually quite hard to quantify. Some of them also are more strongly associated with the risk of malignant transformation and some less so. So there are problems with using so many different criteria, but this is what we have to work with. And so I'm going to show you some examples, to help you out. So firstly, I just picked any oral mucosa that didn't show any dysplasia just to start off this discussion. So in normal mucosa, which may or may not be keratinized depending on the site, and which may or may not have rete ridges, again, depending on the site, the features that we look for to say that there are no dysplasia is that we should be able to see stratification quite clearly. In other words, we should be able to define each of the layers quite easily. So for example, in this case, you can see there's a clearly defined single basal layer. The cells are a little bit more hyperchromatic. They're not crowded, and they're sort of palisaded as well. Then you have a well-defined spinous layer where the cells are more have more eosinophilic cytoplasm. They're more polygonal in shape. If you do have orthokeratinization, you'll have an obvious granular layer and then perhaps a keratinized layer. So now going on to dysplasias. Firstly, not all features that I showed you in the World Health Organization list have to be present in a specimen for one to be able to diagnose something as dysplasia. Sometimes a specimen can have only one feature. Sometimes a specimen can show multiple features. It's more a case of you judging whether there are enough features to make dysplasia. And the other thing to note is that multiple degrees of dysplasia may be present within the same specimen. So here in this particular slide, I'm showing you areas of what a mild dysplasia, and I'll show you what mild dysplasia is in greater detail. And then an area where clearly the epithelium is much thicker, it's hyperplastic, and going over to this side, it's markedly hyperparakeratotic. You'll also see that the rete ridges are thicker, they're somewhat bulbous. There's an increase in nuclear size, the nuclei are hyperchromatic, and this extends not only from the basal layer, but it extends up into the spinous layer too. And in addition, you see areas of intense eosinophilia, which are areas of premature keratinization. Other features you may see, so instead of the epithelium being thicker, the epithelium may be atrophic. So in this specimen, this is sort of normal epithelium. This is at the edge of the resection. And here you'll see that the epithelium is atrophic in this case. So atrophy is another architectural feature of dysplasia. And in this case, instead of parakeratosis, you've got orthokeratosis with a clearly defined granular layer. And you see that there's loss of the normal palisading of the basal layer, and there's crowding of the basal cells. And the basals and the cells themselves are quite hyperchromatic with slightly enlarged nuclei. Another architectural feature is a verruciform configuration. So this is not papillary. With verruciform, we mean that the epithelium itself forms these spikes, and the spikes may be sharp, as you see in this particular example. And the spikes are produced by excess amounts of keratin, in this case, orthokeratin. You'll also notice that the rete ridges are somewhat elongated and somewhat thicker as well. And the other feature to note in this particular specimen is that the cytologic atypia isn't very striking. So there's actually, in this case, a low degree of cytologic atypia, but there's a verruciform architecture to the epithelium. And so I usually call this a verrucous hyperkeratosis. In this case, I'd probably call mild dysplasia because I consider the verrucous morphology a feature of dysplasia. It's very important not to confuse the verrucous hyperkeratosis with the filiform papillae on the tongue dorsum. So that's why clinical context matters. You'll also notice that in the previous slide, the keratin is the one that is undulating and is more or less parallel with epithelium as well. And this is in contradistinction to that on the filiform papillae, where you just have these keratinaceous processes extending outwards. Dysplasia is often also characterized by an abrupt transition between with a normal mucosa. So here's relatively normal non-dysplastic mucosa and an area of clearly high-grade dysplasia right next to it. And here you see that architecturally you have these drop-shaped rete processes where the base of the rete process is wider than its isthmus, where it joins the rest of the epithelium. Clearly, you can see there's proliferation of the basal cells in here to form these very bulky processes. Again, this one is characterized by parakeratinization, increased nuclear size and staining, and in this case involving virtually the entire thickness of the epithelium. I mentioned before that epithelial hyperplasia used to be considered a feature, is not included, but there is an increase in the number of squamous cells in this particular specimen. So the result is that there's acanthosis as well. There's elongated and somewhat thickened rete ridges as well, again with changes in the basal layer. And you'll also notice that there's a lot of eosinophilia in the spinous layer, and that's due to premature keratinization. Other features, here I'm showing you drop-shaped rete ridges, marked variation in size and nuclear staining. So some nuclei larger, some stain more darkly than others, increased nuclear cytoplasmic ratios. This one is also associated with an inflammatory infiltrate. And, this raises a question of inflammatory atypia, which I'll discuss in a little while. Okay, so let's go into grading. So I'm going to mostly talk about the three-tier grading system. As Lingxin mentioned before, most of us tend to consider moderate dysplasia, severe dysplasia, carcinoma in situ as high-grade dysplasia, and I tend to go by that maxim. So low-grade dysplasia or mild dysplasia, the findings are confined mostly to the lower third of the epithelial layer. So I do use thickness as part of the criteria. I don't always use thickness. For example, if you have verruciform hyperkeratosis, you might not need changes in the bottom layer to make that diagnosis. But you can see that the basal cells are quite crowded. They're quite disorganized. They're hyperchromatic. There are mitoses. There's I wouldn't call it a high mitosis, but it is a mitosis above the basal layer. So this one I would grade as mild. This one is characterized by quite a bit more eosinophilia because there's premature keratinization. But in this case, the changes are still confined to the lower third, again with crowding of the basal cells. And so this one I would also grade as mild. So when the changes extend higher up into the squamous epithelium, then we're considering higher grades of dysplasia. And in this case, you're seeing premature keratinization. these very brightly eosinophilic cells extending up into the mid or high areas of the squamous epithelium. You could argue that this could actually qualify as severe because the eosinophilia is going just above, almost to the level of the granular layer. But the reason that I would downgrade this to moderate is because there's a presence of an inflammatory infiltrate. So Lingxin asked a question, do you downgrade when there's inflammation? I tend to downgrade a bit when there's inflammation. So this one I would have called moderate dysplasia. In this case, there's not as much inflammation, and the premature keratinization extends high up into the top third of the spinous layer. And this one, therefore, I would have called a severe dysplasia, high-grade dysplasia. Carcinoma in situ is a term that not everyone uses. When I do see full thickness involvement, I think that most of us at Sinai, we tend to call it severe dysplasia, in brackets carcinoma in situ. In this case, there's full thickness involvement, irregular stratification, loss of polarity. This one, keratinization, is not as obvious. There is a bit of ulceration in this area, but I think that the degree of dysplasia is seen quite distant from the area of ulceration too. And that's why I would grade this one as a severe or dysplasia or carcinoma in situ. As I mentioned, varying grades of dysplasia may be present within the same specimen. So what seems to look like a low-grade dysplasia at lower magnification and areas of higher grade dysplasia. The convention is that the final diagnosis reflects the highest grade of dysplasia. So if there's severe dysplasia and the rest of the specimen shows mild, the convention would be to sign it out as severe epithelial dysplasia. If the severe dysplasia, for example, is only very focal and the majority of the specimen shows low-grade dysplasia, I think it's appropriate to say something like, to make a comment like most of the specimen shows mild dysplasia, but there is a small focus of severe epithelial dysplasia. Or another way of stating it is saying, oh, there's focal severe epithelial dysplasia rising in a background of mild dysplasia, so something like that, just to reflect that, there are differences in grades within the specimen. So this is just the same specimen I showed you in the previous slide. And this is just to show the area of high-grade dysplasia, and then an area where I find that it's quite difficult sometimes to decide whether something is low-grade dysplasia or whether something is not dysplastic at all. I would find this particular part hard to define. And sometimes I might use a wiggle room, like saying negative for high-grade dysplasia, just to describe it, depending on the context. So I've discussed grading at breakneck speed. There are special situations to consider in the assessment of dysplasia, and I'm going to discuss these four different histologic entities and disease entities. So I'm going to talk about HPV-associated oral epithelial dysplasia, the clinical condition, which is called proliferative verrucous leukoplakia, what to do when something looks like a noid, and then when is something reactive atypia or when is it not, because these are all the conundrums that we face. So HPV-associated oral epithelial dysplasia is not that common. In the textbooks, it will say approximately 25% of cases of oral epithelial dysplasia are HPV related. I'm not sure. In our practice, we don't see as high a prevalence, but we do see it. And the trick to recognizing it is that the dysplasia tends to look rather basophilic. So this is what is relatively normal epithelium on this side. And the rest of this looks rather basophilic, very busy, very cellular. The other thing is that the basophilia is contrasted by the pink eosinophilia of the keratinization. So, that should give you a hint to start thinking about, could it be HPV associated. The degree of dysplasia can vary, in this case, it's almost full thickness carcinoma in situ. And the cells characteristically have very high nuclear cytoplasmic ratios, very little cytoplasm. Mitoses are often very plentiful. Apoptotic figures are very plentiful. And the other thing that's characteristic of it is that there's a very abrupt transition between the dysplasia and the non-dysplastic epithelium. And sometimes you might see block areas as well. So this is the one time that I do use adjunctive studies. So the study I use is a P16 stain. And this stain shows the block positivity and then the relative negativity of the non-dysplastic epithelium. And you'll see that the majority of the squamous cells will show both very strong nuclear and cytoplasmic staining. And then it can always be corroborated with, demonstration of, HPV, in this case with RNA in situ hybridization, where you see these tiny little brown dots signifying the HPV. Another setting to be careful of is the clinical setting of proliferative verrucous leukoplakia. So this is a clinical diagnosis, and it's a condition in which patients develop multiple persistent white lesions that ultimately have a very high risk of malignant transformation. So these are all clinical photographs from the same patient. She's got very thick white areas on the gingiva, on the tongue as well. Sometimes it's verrucous, sometimes it's flat. And the reason I bring it up is because verrucous hyperkeratosis, I showed you examples of it earlier, is often characteristic of this condition. So sometimes if I get a biopsy that shows this verrucous hyperkeratosis, and I'm given the clinical information that the patient has multiple white lesions elsewhere in the oral cavity, I might put a line like, verrucous hyperkeratosis may be a feature of proliferative verrucous leukoplakia, clinical correlation suggested. So the big problem we often have is when there's ulceration, when there's inflammation, how do we tell the difference between a reactive atypia and, true dysplasia? So I'm showing you a specimen here that has extensive ulceration on the side, and, the epithelium that's intact shows marked parakeratosis, has these elongated VT ridges, and is showing quite a lot of nuclear hyperchromasia even at this level. There's a lot of inflammation present. So there's, mitoses are quite frequent in reactive conditions. So I wouldn't use mitoses as a diagnostic criterion. But you can see that there's a lot of hyperchromasia, crowding. So one of the features that you look for is areas distant from the area of ulceration. So I tend to look at areas far away, and where there's minimal inflammation, I have to say that there is still a lot of inflammation in this area, but I would tend to look at areas distant away from it, and I would, and if those areas look non-dysplastic, I would tend to move more towards a reactive atypia. There's also another clue in this one that actually slipped in. So if you look at the stromal cells, you'll see these stellate stromal cells that are quite hyperchromatic. So there's actually stromal atypia in this one, and this one was a bit of a trick one because I put in a specimen from a patient who had radiation treatment to the area. So this one I would have favored reactive atypia. When is it not reactive? Well, as I said before, if you look distant from the area of ulceration, distant from the area of inflammation in non-inflamed areas, if there's still dysplasia in those areas, then it probably is not reactive. And I would also look at the grade. For example, in this one, there's severe epithelial dysplasia, which is in excess of what I would expect for an area of ulceration. So if I graded this, I'd probably downgrade it. So if I looked at just the epithelium without any context, I'd probably call it severe. but in the presence of inflammation and ulceration adjacent to it, I'd probably downgrade this one to moderate. The other problem we have is lichenoid inflammatory infiltrate. So lichen planus is pretty common in the mouth. And quite commonly with dysplastic lesions, we see these band-like lymphocytic infiltrates just below the epithelium. This epithelium is clearly dysplastic. It's got hyperchromatic nuclei, crowding of the cells, marked, keratinization extending into the spinous layer. So I think that the degree of cellular atypia here and the architectural atypia is greater than expected for lichen planus. So this one I would not even sign out as lichenoid dysplasia. I would call it out straight as dysplasia. There are other times where it's a bit more difficult, where the epithelial atypia is not as obvious. But when you look at this one and you look at the side, you'll see that the rete ridges are starting to become quite elongated. They're starting to become quite thick. You should not find this with the lichen planus, right? With lichen planus, they tend to be more sawtooth because of the effect of the lichenoid infiltrate on the basal keratinocytes. So, when they start becoming bulbous like this, this I would consider dysplastic. So I've covered grading of dysplasia at fairly high speed. Lingxin is now going to make you grade dysplasia, so we'll see how well I communicated the concepts with you. There are a couple of papers that you can consult to give you ideas on grading as well. And then, of course, I use the World Health Organization fascicle.
Okay, thanks, Iona. Thank you for the great introduction or covering not so basics of oral dysplasia. I know like the current guidelines give us a basic for grading these lesions, but from time to time we have to show these some challenging cases to our colleagues. To facilitate discussion, before Kevin does his talk, we prepare some cases for people to have a brief poll. It's the first time we do this, so like bear with us if this works. So I'm gonna show these whole scan images, and I'm gonna zoom in like in more representative areas. So this is the transition. Okay, Jenny, do you want to just send out the polls? All right, we have over 50 participants. For time, interest time, and we can move on to the second question. So we have 72 people saying it's severe dysplasia. Okay, it seems that the majority of us believe this is HPV related. So we're gonna move on to second case. I think actually this may be the worst looking area. Yeah. Let me see if I can find an area without less of foes. All right. So far, we have 63% of people saying moderate dysplasia and 25% saying severe dysplasia. Okay. Next question for this case. All right. I think most of us think this is non-HPV related, either with or without a p53 mutation. Moving on to case 3. Zoom in this area. Just keep moving. Yeah, I think the initial areas that we showed, like we got some answers on mild dysplasia, and then as I show more areas, people are leaning towards moderate or severe dysplasia. Okay, next question for this case. I hope this interactive case discussion is helpful because we have been doing a more traditional presentation, but I feel like it's nice for people to see, like what's the consensus. I know it is not like a good simulation of a real practice because you're only given limited time for these. Okay, again, similar to the last case, most people think this non-HPV related, either with or without p53 mutation. Okay, moving on to case 4. I think that's a good area. All right, seems that we have a pretty good agreement on severe dysplasia on this case. Next one. So next question for this case. Okay, it seems that people can really have a good agreement whether it's HPV or related or not. Okay, we're going to next case. This is case 5. And this is a transition. Okay, I think most people think this is either moderate or severe dysplasia. 71% of saying this is severe dysplasia. Next question for this case. All right, so about 60% of people saying this is HPV associated. Well, others think this is not. Okay, going to do the last question before Kevin's talk. I think people are having trouble with this one because we have so far 35% of responses. Hmm, Just go back to the first place. Okay, so 80% of people favor this be a reactive. Since the most of us think this is reactive or not, I'm gonna ask you the mutation status. All right, thank you. Thanks, Jenny. I'll stop sharing. So just we'll take advantage of having experts and panel. We'll probably wrap up our session by re-looking at the cases we sent out to people. And we showed just before Kevin's talk. So this is case one, and most of us think it's HPV associated severe dysplasia. This P16 showed block-like positivity, and like Kevin, I don't think people, most of us have been trained or like have trained our eyes on a lot of experience with this basal sparing pattern P53. So Iona, Kevin, you two are feel free to chime in. So this is the a good case we're showing. This is a non-neoplastic pattern, the wild type, and then this basal sparing. Second case. Okay, most of the things is moderate to severe dysplasia, non-HPV related. So this is the normal and this dysplastic pattern. So it has a basal parabasal to diffuse P53 staining pattern. But Kevin, even the P16 looks a little bit unusual. It seems all the staining condensated towards the basal layers. And third case, I think again, we believe this non-HPV related, P16 and P53. This is one of the more interesting cases where there was a cytoplasmic P53 staining in contrast to the wild type over here. And the fourth case, I think people are having some disagreement on whether this is HPV related or not. P16 has block-like positivity, but this case didn't stop there. It's actually also P53 aberrant. So Kevin, do you want to comment on this case?
Yeah, so we collected actually seven cases of this double positive P16 block positive and P3 mutant cases, dysplasia and SCC. And we believe we found the explanation why P16 is false positive. And we have each done in these cases, and in most of those cases we sequenced already. So that's pending. We're hoping to publish this soon. But this is also accepted in the vulvar GI literature. When you have a block positive P16 together with a mutant P53, the PCC tend to be false positive and likely not HPV associated pathway.
Okay. Uh, just want to finish all the cases. This is number 5. I think like after the last case, you know, people are like less sure about HPV versus not, but this case is HPV related. It has a block-like positivity and basal-sparing P53 pattern. So I guess, when we don't have full thickness, not like severe dysplasia, maybe people may not recognize the HPV uh, relation very well. And the last case, this is probably the case that you showed in your presentation, Kevin. So this is a case with syphilis, and P53 has a wild type pattern. Okay. All right. So far, um, we have 10 more minutes. Do you have any last minute questions? So it occurs to me that Dr. Anna Platkin, who's also sitting in the audience, practice gynae pathologist, and she commented that in the gynae world, we routinely do P53, P16 on in the relevant cases. Um, can you, Anna, if you're still here, can you comment on, what is the selection criteria for the relevant cases where you apply the immunostains on? With the understanding that, we probably get a lot more biopsies from our dentist or pathologist. when it comes to oral dysplasia?
Yeah, so we will do P53, P16 on all cases that look dysplastic. So anything that looks like HPV, like basaloid type of dysplasia, we will do it because a lot of the times it's actually P53 associated and not HPV. That's what the literature have shown, and that work from that Kevin showed from Lin Hong. That was exactly about that. That's number one. And number two, we apply P53 quite easily on anything that looks a little bit unusual in the basal layer. Let's put it this way. Because again, based on her work, what we realized in the dysplasia next to invasive squamous cell carcinoma, a lot of the times P53 is abnormal and it was not picked up by the pathologist. And quite often that devian would extend to the excision margins and the patient will come back because we could not recognize it.
So I guess a lot of the HPV related studies are focused on oral pharynx, where like in the more typical presentations, where the patient presented with nodal disease and etc. So what is the current evidence on HPV related squamous dysplasia, either in the oral cavity or in the femogenital tract? So do they actually behave better than the p53 mutated dysplasias?
Yeah, again, that work from UBC, and I'm sure Kevin is aware from Jessica and Lean have shown there is significantly worse prognosis with the P53 abnormal lesions. First of all, deviant progresses very quickly to squamous cell carcinoma, and the squamous cell carcinoma that is P53 aberrant behaves significantly worse. Clinically, there is huge separation of the curve between the two.
And
Yeah,
how
that's
about
also
yeah,
go for
sorry,
it.
go ahead.
That's also my experience. The moment I realized P53, where you're talking about using one stem, can tell you whether it's HPV associated or P53 mutant. And then I'm yet, and I'm struggling here. I'm yet to find a case that's HPV dysplasia in the oral cavity. That's severe dysplasia and progress to invasive SCC. And I've seen quite a bit now of cases. They do occur, but there's definitely not a high percentage as the P53 mutant cases. And that's why I reached out to Dr. McCord about this because she had a large collection of HPV dysplasia cases, and she has very similar experience that we're working hard to get this published. So my opinion is risk of progression for HPV associated oral dysplasia, even though most of them will be called severe, likely is not as high, nowhere near as high as P53 mutated dysplasia.
Okay. Thank you so much again. Thank you, Ina. Thank you, Kevin. Thank you all the audiences for this great session. And Kevin, we look forward to seeing more work from you, and hopefully our platform provides some opportunities to collaborate across Canada even beyond that. So I think Kevin left his email address in the chat, and you have my email address. Know how to contact us. So feel free to let us know your feedbacks or any questions. And our next COI meeting is probably planned in April to May. We'll announce the dates on our COI website. Thank you. Thanks, everyone. Have a great weekend.
Thank you so much. It was great.
Thank you, Anna.